Thank you so much, everybody, for getting back here so promptly. We're clawing back the time we lost this morning, which is great news. We've moved. I think we're going to move now from this space where we've been looking at drug delivery to, I sort of see these as perhaps slightly more practical, this practical space where we're talking about neurosurgery and electric field therapy and communication during consultations, and that will take us up to lunch at 12:45 with some space for a discussion. Our next speaker is Dr. Stuart Smith, who is a neurosurgeon at Nottingham University Hospitals working with young adults.
Adults and young adults.
Adults and young adults. Yeah. And he's going to be talking about advances in surgery for brain tumours for the next 20 minutes. Thank you.
I'll try and keep to time. Thank you. Thank you, Will. Just a warning, that obviously this is a talk about surgery, and there are a couple of videos of operations and some of the techniques I'm going to talk about. I'll try and give you a warning when they're coming up. They're not too gory. Hopefully you'll find them interesting, and they'll illustrate some of the things I'm going to talk about practically. But obviously there are live videos of actual operations. They're not not patient identifiable, obviously, or the patients have given consent for them. But if anyone's finds that difficult, then please feel free to leave the room for those few minutes. So I work at, as Will said, at the Nottingham University Hospitals Neurosurgery Unit. We're one of the largest, busiest brain tumour units in the country, and we cover in general the East Midlands, which is Nottinghamshire, Leicestershire, Derbyshire. We also cover a considerable proportion of Lincolnshire, sort of southern 2/3 of Lincolnshire, and a chunk of Staffordshire around Burton as well. We cover about a catchment population of about 3.5 million adults in the UK. Our paediatric catchment population is slightly higher. We probably cover a 5 million population for that. And again, we're one of the busiest paediatric brain tumour centres, and we obviously liaise closely with the Children's Brain Tumour Research Centre, where I work part of the time. And we have very close links. Myself and my other neurosurgical colleagues work closely with many of the PIs and the projects that have been talked about today. Neurosurgery is the speciality dealing with surgery of any disorder of the brain, spinal cord and nervous system. Obviously, my particular interest is brain tumours, and brain tumour surgery makes up about a third of the neurosurgery department's workload, but we also deal with head trauma, bleeds on the brain, aneurysms on the brain. We also do some spinal surgery, and we also have a functional neurosurgical practice, which I will talk about a little bit in my second talk when we're talking about electrical therapies to the brain. So I was asked to talk about developments in neurosurgery, and I'm going to go right back to the beginning of neurosurgery and talk about, from the very early days of neurosurgery up to modern times. So neurosurgery, actually, interestingly, although maybe sounds in some ways quite a modern speciality, is one of the oldest surgical specialities that we have evidence for. So in very ancient times, the phrase you talk about releasing the evil spirits, and that actually was an operation. Where trepanning or drilling holes in the skull was used as a way of trying to deal with disorders of the nervous system and disorders of that people felt were related to these sorts of things, and they clearly didn't understand the biology behind them, but they released pressure, I guess, in some circumstances, and thought it might be successful. And neurosurgery really developed, as a lot of things do, out of war in the Middle Ages, where people had head injuries, and ways of dealing with that were decided. And these are very ancient skulls from Stone Age times, and that top skull's been trepanned. That poor soul has had the evil spirits released, and these are the sort of tools they used to use just to sort of grind away the bone. And miraculously, some people even survived the operation. And you can see here that the skull is filled back in on this individual, and they clearly survived the surgery and lived long enough to produce new bone. As I say, in the Middle Ages, we've got sort of illustrations of being a very early neurosurgeon here, taking usually bits of bone out of people's heads once they've been sort of clonked on the head with one of the implements on the right. So sort of modern neurosurgery, as we understand it, really came about sort of in Victorian times, and one of the key things was really being able to localise and understand the functions of the brain. And that really came about with this chap who was Phineas Gage, and he was a labourer on the railways in 19th century America. And he was, by all accounts, a very sober, hard-working, family-orientated individual. I think he was a Quaker, and he worked on the railways, and his job was to dig the little pits and sort of tamp explosives down into the pit with that big rod that he's holding. And you know, health and safety maybe not being quite what it was in those days. Unfortunately, one day the explosives went off while he was still sort of pushing them down, and it blew the rod up through his skull, as illustrated. And miraculously, he survived and was able to walk and talk, and you know, by all accounts looked reasonably normal afterwards. But his personality had completely changed. He unfortunately became an alcoholic, and lost his job and had a very difficult time. And really, people then began to understand that, in this case, the front parts of the brain controlled things like memory, personality, inhibition. And from then on, various other experiments, various other studies showed what the other parts of the brain do. And that really allowed us to start to focus with neurosurgery and to assess where problems were, and obviously specifically where tumours were, and to localise down and to make our operations smaller and safer and quicker. We've gone from using sort of mechanical frames like that in medieval times, and now we've got a robot that does the same thing. So that's progress for you. So the first ever brain tumour operation was done in Victorian London by Godley. Bennett was a neurologist who helped him to sort of localise the tumour. And it was done in a hospital called Regent's Park Hospital, which no longer exists, but actually is the site of London Zoo. So if you ever go to London Zoo, that's the site of the world's first ever successful brain tumour operation. And Godley, under direction from Bennett, scooped out the tumour using a silver spoon, as it says in the case report they published in Lancet. So that was the very first brain tumour operation. We operate on a wide range of patients, really of all ages. As I'm sure people are well aware, brain tumours can affect people of any age. They're a major disease, or major cancer-related disease in children and young adults. But also, in older adults as well, there is a high preponderance of brain tumours. When we think about a tumour as a surgeon, we sort of start to look at it and we think about whether the tumour is extrinsic or intrinsic to the brain and the spinal cord. So the extrinsic tumours tend to be things like meningiomas, which develop from the lining of the brain. So although they may be sort of almost within the brain, they're actually separate to it, and if we're lucky, there's a nice plane between them and the brain, and we can separate them away more easily. Now the intrinsic tumours, which unfortunately the majority of childhood brain tumours are actually within the brain itself. They're within the substance of the brain. Now there may or may not be a sort of edge to them, but we certainly have to go through some normal brain or disturb the normal brain to get to them and operate on them. The location of the tumour is also of great importance to us as surgeons, and again that sort of to some extent dictates whether we say something can be dealt with by an operation or not. So on the one side we see a superficial tumour right in the frontal lobe of the brain, and that would be on the non-dominant side for the patient in all likelihood, and we can get to that tumour without having to go through brain, and we can it's not near any two vital structures, and that makes it a lot more attractive to us as surgeons in terms of thinking we can get a good result from the operation. On the other side, this is a tumour that's right within the middle of someone's head, in the midline, and spreading through different compartments of the brain. That's much more difficult for us to remove. It's not impossible, but it makes the operation longer and trickier and more risky. And unfortunately, a lot of childhood brain tumours do sort of fall more into the second category. We talked a bit about the edge. Sometimes there's a very obvious edge for certain types of tumour, but in other types it's almost imperceptible where the tumour is as it spreads through the brain. And clearly that is much less accessible to us surgically. We can biopsy it or remove part of it, but we can't define where to start and stop the operation to such an extent. the outcome from surgery is obviously very variable, and we know that for most tumours, the more we can remove surgically, the better for patients and their longer term outcomes. But clearly we have to balance that against the risk of causing damage to the brain. And our aim is normally what we would call maximal safe resection, i.e. to take away as much of the tumour as possible, hopefully all of it, but within the bounds of what we would consider to be safe, with causing minimal disturbance and damage to the brain. And that's a very difficult balance for us to strike, and it's really the key dilemma for surgeons and for patients and their families is, how aggressive should we be with surgery? And obviously many of the projects help to inform that, and we know that if we have a good treatment, we can follow up with surgery. We can sort of dial back a bit on how aggressive we might be and hopefully spare the brain and cause fewer side effects and fewer complications for patients. Here's one of my colleagues doing an operation with one of our theatre sisters. That's kind of what our theatre looks like. These are the sort of things we operate on, and obviously modern scans, modern imaging, a CT scan and an MRI scan there, very key, and that really we're entirely dependent on the imaging to guide us and to direct us to the operation. It can be very difficult for us to ascertain exactly although it can look very different on the MRI scan, actually when you're in theatre with the naked eye, it can be very difficult to tell what's tumour and what's brain, and again that's a key dilemma for us, and many of the techniques that I'll describe have really been developed to aid that process. So one of the first things we do is, or one of the main techniques we use is something called image guidance. This is based on the pre-operative MRI scan or CT scan, and we build a sort of model of the brain electronically. Now you may have seen on sort of history programs where they find, Richard III or what have you in the ground, and they do a scan of the skull, and then they rebuild a model a bit like this, and then they can, say this is what Richard III or Tutankhamun or whatever looked like. So it's a similar sort of process. We build a model of the patient's head virtually on the computer, and then using sort of infrared tracking, we can monitor this probe, and the screen tells us exactly where the tip of the probe is, so we can see exactly where we are on the scan. Now the difficulty with that is it's fine in that it's based on the preoperative scan, and it can be very accurate to less than a millimetre. But as soon as we start operating, actually things start to move. We cause shift in the brain, so the scan actually becomes less accurate as time goes by. So one of the ways to get around that is actually to repeat your scan during the operation. Now it's not very practical to take a patient out of the operating theatre all the way down to the MRI scanner, do another scan and then come back up again. But technology exists such as intraoperative MRI, and also things like intraoperative ultrasound, which we use pretty regularly at the moment. But intraoperative MRI is the next stage of that, a bit more accurate, particularly for childhood brain tumours. So this is one version of it where you have a small MRI scanner in the theatre, the surgeon there sort of crouched in between operating. So that was a sort of older solution, but the more modern solution, and one that we're hopefully developing in Nottingham, is to have effectively a proper MRI scanner, a full-scale MRI scanner in the room next door to theatre, and you have the operating table on sort of train tracks, tram tracks, and at certain stages during the operation, the neurosurgeon can slide the patient out into the scanner, update the scan, update your image guidance, and give you a much more accurate picture to see if any tumours left behind, you need to do a bit more, have you done enough already? And that allows you to hopefully achieve better rates of resection, particularly for childhood brain tumours. As many of you may be aware, there's the Nottingham Children's Hospital big appeal going on at the moment. This is one of my colleagues, one of the paediatric neurosurgeons, Mr. Donald MacArthur, who's sort of leading the appeal from the surgical point of view. And we're really at a very advanced stage now, and we're really hopeful that 2019 will be the time that this finally comes together and the intraoperative MRI comes to Nottingham. So other adjuncts that we use to actually help improve our resection are things like high-powered ultrasound or CUSA, lasers and neuroendoscopy. So this is what a CUSA system looks like. We often use this in operations. It's a way of sort of trying to remove tumour but obviously preserve the surrounding structures, particularly the blood vessels. And it kind of vaporises tumour tissue and sucks it up the sucker. Everyone always asks us about the laser. We we don't really use it that much anymore, to be honest. We used to have one, but it's very cumbersome. Yeah, everyone in the theatre has to wear sort of special goggles, and to be honest, it doesn't really do much more than you can do with a Cusa. So although it sounds very sort of futuristic, it's one of these technologies that perhaps isn't quite as excited about, isn't quite as useful as we thought it might be. One technique we can use, particularly in young adults and older adults, is awake craniotomy. So this is me doing an operation on a young adult with a brain tumour. The patient's awake there, and they have a nice chat with that nurse behind the screen. You know, where'd you go on holiday last year? It's a bit like having a haircut, and but they have a nice chat with one of our chattier nurses, and we get on with removing the tumour and obviously test various functions during the operation. And that allows us to be absolutely sure that any bit of the brain that we're planning to remove, or any bit of tumour that we think might be removable, we can test it beforehand, make sure that it isn't going to affect any function. And it's a way, again, of maximising resection, but in a safe fashion, without damaging function in the individual. And most patients actually are pretty good with it, and afterwards they nearly everyone sort of said it wasn't quite as bad as they thought it was going to be. Another issue we have that the drug delivery talks and spoke about was, although the scan may show an apparent edge, actually there's tumour beyond that edge for certain types of the more aggressive tumours particularly. So how do we deal with those cells beyond, and how do we get to the bits of tumour that we can't really see on the scan? One way of doing this that we've introduced in Nottingham a few years ago, and we were one of the first UK centres to introduce this, and has now been recommended by NICE as a standard of care for patients with glioblastoma, is something called fluorescence-guided surgery. So we give the patient a drug called Gliolan, or the long name's 5-ALA, and effectively this makes normal brain go blue under special light and makes tumour go pink. So the next slide, I think, is a video of a patient having 5-ALA guided surgery. It's a sort of close-up of the brain, and I'll just to warn you that it's an operation. It should work, yeah. So this is sort of the view under normal light, and there's a sort of hole already been made in the middle of the tumour, and the whiter, creamier stuff around the edges is the normal brain. This is under the blue light, and you can see the sort of surrounding brain is a sort of lilac-y blue colour, and I think we will clean it slightly. So the pink area is there where the sucker is tumour, and there's another area up there where the sucker is now. So those pink areas are areas of tumour cells that are glowing pink under the influence of the 5-ALA and the blue light. And that really helps us to distinguish that from normal brain, because you see that's sort of a little bit away from where we're operating, and we might not necessarily have picked that up. I'll skip over Glidol because we've obviously talked a bit about that already. One of the other techniques you may hear us talk about, or you may be familiar with, is endoscopy. So that's basically telescope or keyhole surgery, and it's very good for certain things, but you do need a space to put your telescope into. You can't just put it into solid material. You either need a fluid-filled or an air-filled space to use that. So you can use it, particularly in children. We often do surgery via a telescope into the ventricles, the fluid-filled spaces, because, as I say, a lot of childhood brain tumours are around or in contact with those fluid-filled spaces. But we also use it in the air-filled spaces, the sinuses, where you get your sinusitis at the base of the skull. We can put a telescope up there to get to the base of the skull, and tumours, particularly in the pituitary gland, and things like craniopharyngiomas that again occur in childhood in those areas. Oops, sorry. Sorry, another operative video. So this is looking up someone's nose, basically. So if you keep going up the back of someone's nose, you get to here. That's the carotid artery, that sort of curvy thing in the middle. And the bit at the top is the dura, the underside of the brain. And the bit on the left is where the tumour was. I think this was a craniopharyngioma in a teenager. And obviously, this is very good because we can get a really nice close-up view with our telescope. Doesn't leave any scars as well. So we got right up the nostril, up the patient's nose, no scars on their face. So it's really, really attractive to patients from that point of view. And I'd say for certain tumours, this is a really nice technique that's sort of been introduced in the last sort of 10, 15 years, I guess. I think that's sort of jammed, but that was basically the end of the talk. So I hope that's given you a flavour of some of the techniques we use. I'm obviously happy to take questions and answer any things at the break as well if people would like.
Thank you very much. Stuart, I'm right in thinking you'll be coming back shortly to talk about, we stopped your talks, it's electric field therapy, is that?
Yeah, I think Shelley's going to.
So we've got that coming up. But before then, this is an area that is particularly interesting to me and the team here at Brains Trust, where we're looking at kind of this space where, you know, you're not in hospital, you're not necessarily looking for a cure, you're just trying to find your new normal once you've gone through treatment for a brain tumour, you're back home trying to make sense of life. So I'd like to introduce Shelley Stubley. Shelley is a research associate and PhD student working at CBTDDC, the Children's Brain Tumour Research Centre here at the University of Nottingham. Her research interests, and correct me if I'm wrong, include health, anxiety and quality of life, patient-reported outcome measures, and the use of technology to improve outcomes in healthcare. So Shelley is going to be talking about the PROMOTE study that she's involved with. Is that correct?
That's it, yeah.
That's it. The slides are working. No, they're not. There we go.
Go. Thank you. Thanks for that. Okay, so I'm going to talk about the PROMOTE study, which is a study to look at quality of life and communication needs with children and young adults that have had brain tumours. I work with Professor David Walker at the Children's Brain Tumour Research Centre, and the study is funded by the Brain Tumour Charity. So, what have I done? Sorry. Thank you. There we go. Yeah, so as you're probably all aware, life can be quite different for children and young people after a brain tumour. And at the moment, there isn't a routine way of asking about changes post-treatment. So children get better and they go home, and we don't collect data in a routine way. So the study that we're carrying out is to try and find out if we can introduce a way of doing that that's helpful, both in recording what happens and also in increasing quality of life for these children. So the study is based on something that's already happening in Holland called CLICK. And so all children that are treated in children's hospitals in Holland use this method of communication. So before they go for a follow-up consultation, they fill in an online questionnaire, and the consultant sees that a couple of days before the child goes in, and it alerts them to any issues that are important and that they need to talk about. So these are things like school and how well they're feeling, how they're feeling emotionally, and any issue that could be important for quality of life. So this is a study that's being carried out at 3 different centres. So there's Nottingham, Great Ormond Street Hospital and Southampton Children's Hospital. And we've just finished the development phase of the study. So at each of the 3 centres, we've interviewed 6 families. And we try and interview the children and their parents separately, because we think that gives them both a space to talk and say things that they might not feel comfortable saying in front of each other, but that doesn't always work. And the youngest children we've interviewed are 8 and the oldest are 17. So we've got a good age range. And although I do know the condition that most of the children have had, it's not really important. I like to go and meet the families without knowing much about them, so I can sort of meet them fresh, if you know what I mean. So we've interviewed the families for the first part of the study, and we've showed them the website, the CLIC website, and we've talked to them about communication issues and about their quality of life, and we've asked them which questionnaires they like. And people said that they liked more straightforward questions, they liked ones that were easy to answer and didn't take long. But there were also some missing questions. So there were the PEDSQL, which was the most commonly chosen questionnaire some of you might be familiar with. It didn't ask about some issues which families told us were important. So they were things like memory, communication problems, worries about fertility, that sort of thing. Like most children and young people, they had nice lives, most of them. They had sports they enjoyed, they went on nice holidays, they enjoyed being with their families and their friends. But they told us things had changed for them after their treatment. So sometimes they couldn't go back to playing the sports that they used to play. They struggled at school. Memory was a problem. For some children, friendships were a lot more difficult since they'd been ill, and doing well at school was more challenging, and they struggled with having low energy when they were at school, not being able to complete their homework, and finding it hard to get around school was quite a common problem. So they're the sort of things that they told us. When the children spoke about their consultants, they were really positive. They felt that they gave them lots of information. They enjoyed going back to see their consultants. And they didn't have any problems talking to them, but I think one of the things that we realised was there were a lot of issues that the children just didn't think were relevant to speak to their consultants about. So sometimes they would say, it didn't occur to me that I could talk to the doctor about what was happening at school. Another thing children told us was because they forgot things easily, often they just let their parents talk for them because they were worried they'd forget to say stuff, so they just let their mum and dad talk for them. Some children said that they would really like the chance to speak to their doctor on their own. And we realised that was because sometimes the kids didn't want their parents to worry about them worrying, if that makes sense. And the opposite was also true. Sometimes the parents wanted a chance to speak to the consultants about their child, but they didn't want to ask difficult questions in front of their child, and they also didn't want to say, can I see you on my own, because they thought the kid would just know that there was something worrying them. So it was quite interesting. So the sorts of things that young people wanted to talk about were whether the cancer would come back, whether their fertility had been affected, whether their memory would improve and come back. And then more practical things like, is it okay to start playing rugby again? How far should I push myself with sports? And a lot of worry about weight and fitness and that sort of thing. So here's a couple of quotes from two different children. One of them is describing his frustration about when he comes out of a consultation, and he just couldn't remember what he wanted to say. And the other child is talking about how they just didn't think it was a suitable thing to speak to their doctor about. So when we showed the families the CLIC website, they really liked it because they thought it would help them to remember things. That was probably the most important thing. So they could write it down whilst they thought about it. They could just put it into the website. And then parents in particular were interested in the fact that they could track their child's progress over time. So they could see from 1 6-month appointment to the next how their child had changed or improved. They also thought that if you found it difficult to talk, or you were shy, or you had a communication issue maybe after surgery, that it would help because you could just type it, or you could take your time to talk with your parents about what you wanted to say. And also, some young people thought that communicating in this way would mean they could ask questions that were a bit embarrassing or awkward, and they wouldn't feel so overwhelmed at having to say them out loud in front of maybe 2 or 3 people in a consultation. And people also recognised that if they got the chance to speak to read the answers, the questions a little while before the consultation, that the doctors might have a chance to think about the answers, or even to think about a referral or another possible way to help the family. So the next step is to carry out a feasibility study in each centre, and we're looking for 15 families to take part, and this will involve the families actually completing the questionnaires online, and we've also added a few prompts. So we asked specifically about issues like, is anything else worrying you that you'd like to talk about? How are things at school? So we've asked some extra questions, and we're going to see if it works, and then we're going to get feedback from the consultants and the families to see how it's gone. So if you're interested in finding any more, drop me an email. Thanks for listening.
I have loads of questions, but I'll ask them later. Thank you, Shelley. So we welcome Stuart Smith back to the stage. Now he's going to be talking about electric field therapy for brain tumours. This is I think in terms of public perceptions, a relatively new Parliament on the 25th of January, and she was actually wearing one of these devices. Hopefully now we can find out a bit more about what that involves and what it might mean for the future for children, families, adults. Thank you.
Thank you very much. So as Will said, this is a pretty novel area, and it's a sort of therapy that I guess has been in the media. As Will said, Tessa Jow famously had this therapy on when she was delivering her address to the House of Commons. It is something that's still just really coming in, and it's not something that unfortunately is available yet on the NHS in the UK. And there are difficulties and problems with it, and I'll talk about those to try and give a sort of a fair overview of the treatment. But I'll also talk about some of the other approaches that are in development that may be either more efficacious or safer and kinder ways of delivering this sort of treatment. I'll also like to talk a bit about the electrical therapy to the brain in more general, to give you a sort of background of where we are, and that this is electrical therapies to the brain are actually a relatively well developed field, and have been used successfully for other conditions other than brain tumours by neurosurgeons for some time. As I think it's an area that maybe sounds a bit science fiction-y, a bit sort of quackery in many ways, but there is a solid evidence base and a solid clinical base for the use of electrical modulation of the brain for many disorders, and hopefully this works building on that and bringing the benefits of those developments to brain tumour patients and their families. So there's 3 sort of main areas, or 3 main ways, I guess, of delivering electrical fields that are probably relevant to brain tumours. The first one, Optune or Novacure therapy, is probably the most famous in terms of this is the one that's actually made it into clinical trials and into patients. And I'll talk a bit more detail about that irreversible electroporation, I'm not going to talk very much about, but essentially that's a very, very high voltage delivered through a probe, and has been used on occasion for sort of very focal tumours. So in adults it's been used for brain metastases, secondary tumours that have spread from elsewhere in the body into the brain, as a way of sort of literally just burning those tumours away. I think it's perhaps largely been superseded by developments in radiotherapy, where a very similar effect can be obtained through delivering local single-dose high-fraction radiotherapy, which we would call radiosurgery. And it achieves a very similar thing to that. And I said it's very high voltage and just literally works by electrically destroying tumour material. And deep brain stimulation, which has been used very commonly in other disorders, and one of my particular research interests is in whether we can apply that sort of technology to brain tumours. So the brain is an electrical organ. I mean, all our cells in our body actually are electrical organs. They all rely on electrical currents to function anywhere in the body. But the nervous system, communications, thoughts, actions, control of any organ in the body is achieved by the nervous system through electrical currents. And the millions or billions of tiny connections, the synapses and the neurons between them. So it's been appreciated that electricity can have a function on the nervous system for some time. Initially in very crude ways, in that epileptic seizures can be induced by certain chemicals such as camphor. And really from sort of late medieval times onwards, people tried to use that for various conditions, often psychiatric disorders, with I think very limited success. In the 18th and 19th centuries, there was a sort of vogue for something called galvanism, which again was sort of applying electrical currents to various parts of the body and the head, and trying to stimulate effects through that. And again, I think this was, probably of limited effect. And I think the sort of hangover from those sorts of approaches is often why people are maybe a bit sceptical about whether these sorts of treatments can work. One treatment that perhaps has a slightly darker image is electroconvulsive therapy, and again has been used for some time, and obviously has unfortunately a very poor public image from films such as One Flew Over the Cuckoo's Nest, and perhaps its overuse or the abuse of the treatment in the 50s and 60s and 70s. However, it is applying strong electrical currents to people who are severely depressed with drug-resistant depression at high risk of suicide can be a life-saving measure. And it is still used actually on thousands of people each year in this country, with actually often very good results. And as I say, it can be a life-saving treatment for people with very, very severe refractory depression. So moving on, the next sort of electrical treatment that really came onto the market, and which again probably starting to have more relevance to patients with brain tumours, is vagal nerve stimulation. And this is a bit like the sort of cardiac pacemakers that people have. You have a battery implanted in the chest wall, and then a wire running up into the neck, wrapped around the vagus nerve, which is one of the main nerves that runs from the brain down to the heart and to the bowels. But this relies on stimulating the vagus nerve electrically, and sort of conducting electrical signals, if you like, the wrong way back up the nerve into the brain, and using that to modulate brain function. Now, it's primarily used as a treatment for seizures, for epilepsy, and for reasons we I have to confess we don't fully understand, by stimulating the electrical nerve, again, in people with drug-resistant or refractory epilepsy, you can reduce the number of seizures that they suffer. And it's very effective. It's a proven treatment funded by the NHS, and we regularly put these in for children, adults, young people who have drug-resistant epilepsy. There are some hints that it may even be potentially a treatment for tumours, and there are starting to be studies examining the effect of vagal nerve stimulation on whether that could be used as a sort of anti-tumour measure. The other therapy that came along in the sort of 90s was deep brain stimulation. And again, you have a sort of pacemaker type box in the chest, a wire running up, and Steve Gill was one of the Professor Walker works with, was one of the first people to use these sorts of treatments in the UK. And a bit like, rather than running a catheter into the brain, you run an electrical wire, and that is targeted to particular areas of the brain that are known to be important in particular diseases, particularly Parkinson's disease. And again, it's a proven evidence-based treatment for Parkinson's disease. There's a video. The next slide is a video of someone with Parkinson's disease who has a deep brain stimulator in. There's no blood or gore, but it is a patient from America. If that works. So he's from Louisiana, so that's why we don't speak with this accent normally.
Bilateral stimulators, and we're here for the initial programming session. This is what it looks like without the medicine and the stimulator. Now we're just going to turn it on.
So that's the programmer. The sort of black thing lying on his chest is just a programmer that's just sat on the clothes. It's just for the programming session. Current coming on there. They've turned the stimulator on. You see it abolishes the tremor.
Yeah. Try tapping both your fingers for them. Excellent. All right. Feels pretty good? Very good.
So it can be very effective for those, and it's, as I say, it's a very well recognised treatment now for Parkinson's disease, and its use is being expanded into a lot of other conditions, dystonia, even some mood disorders, even things like anorexia. People are trialling, stimulating different areas of the brain to have, beneficial effects in those conditions. It reduces, a broad range of symptoms in that condition in patients. So that neurosurgeons have quite a lot of experience of putting these in. I say one in Nottingham, we put a couple of hundred of these in now. And the electrical therapy for the brain has now moved on to examine tumours, and really the major thrust of that has been through the Novacure company and the Optune device, and this is what it looks like. So in patients, it's licensed for patients with high-grade brain tumours, particularly glioblastoma, and it works essentially with an array of electrodes on the patient's head that are arranged in a planned fashion to direct an electrical field specifically to certain areas of the brain around where the tumour was or is, and to deliver an electrical field, to deliver voltage into those areas, and we think, as I'll show, that has anti-tumour effects. Now this is a model posing for the photo. The reality is, this chap, as you can see, he's got a backpack on. That's the battery pack for the electrical wires. You have to carry that around with you. You have to have the, it works. Obviously, the more you use it, the better effect it has, and they recommend you wear it for at least 23 hours a day. So it's pretty much all the time. Patients have to have their heads shaved daily to allow the electrodes to make contact. Unfortunately, obviously, that's pretty irritating to the skin, and the pictures here are from a paper where they were showing, people getting rashes and dermatitis in the skin, and there is a substantial commitment, I think, on the behalf of the patient to wear this and to use the device. So we think it works essentially by when a cell divides, all the chromosomes line up in the middle, and they're quite big molecules, and every molecule has an electrical charge. And it's thought that Optune works by disrupting the sort of coming together of the chromosomes when cells divide, and essentially causing that to happen in or failure of that process, or interfering with the cells dividing. And by concentrating an electrical field at that point where the two cells are pulling apart, you stop that process from happening and cause death of the cells. Now, the good thing about the brain, obviously, particularly except in perhaps smaller children, most of the cells in the brain aren't dividing, and the tumour cells certainly, hopefully, are dividing at a much faster rate. And TT fields or Optune has very little effect actually on cells that aren't actually dividing. It doesn't seem to cause too much in the way of side effects. So it has been used in clinical trials in adults with recurrent glioblastoma, where it didn't have a great deal of effect on survival compared to conventional chemotherapy, but had a much better side effect profile. So it seemed to be as good as conventional chemotherapies in this trial. They then did the sort of main trial where they looked at people who were newly diagnosed with glioblastoma, and they did seem to show a benefit in terms of overall survival, perhaps of the order of 3 to 4 months compared to conventional therapy, and a significantly increased 2-year survival rate compared to conventional therapies. And this is to show you, so these are patients that were being treated for their glioblastoma with radiotherapy and temozolomide, and either received TT fields or didn't receive TT fields. And both progression-free and overall survival were increased in the group receiving the electrical therapy. Now you might think that's quite convincing, but it has been met with quite a lot of scepticism from certain sections in the medical and surgical communities. The trial was perhaps not designed to quite the highest standards, and I think that if we're going to disseminate and get public and particularly financial backing from governments and other bodies for the trial, it's really important that any research and any trials are conducted to the very highest standards, so there's no question of it being accepted. The other major issue I should mention with Optune and Novacure is it's phenomenally expensive. It costs £20,000 to £30,000 per month. Now that's largely to do with the fact that you need an engineer to check the position of the electrodes and check that you're getting the current delivered correctly on every few days. So there's a huge labour cost, ongoing labour cost for the company that obviously they have to recoup. And unfortunately, at the moment, the cost is extremely high. Now, I sat on the NICE Guidelines Committee that looked at treatments for primary brain tumours, and although we felt that, on balance, Novacure probably did give a small degree of benefit to patients, it's very difficult to justify committing that amount of NHS funds at that level of pricing. Now, if the cost came down, I think it would be approved and it would be available, but you're essentially paying for a specialist nurse post for one patient for every month that they have the treatment, and sadly, living in a world with a fixed finite pot of money, the committee didn't feel that spending that amount of money was the best use of those sorts of resources. Now, as I say, I think discussions are ongoing between the Department of Health and the company, and if the costs were to be reduced, then I think adoption could happen probably fairly quickly onto the NHS, but it would need a substantial movement in terms of pricing. So just to talk about some of our in-house research very quickly, as I mentioned, deep brain stimulation we also feel could be a potential, and it overcomes some of the difficulties with Optune. It's all internalised with deep brain stimulation, so it's once the device is implanted during an operation, it's all internalised. You don't have to carry around a big backpack of batteries. You don't have to have your head shaved every day. And once it's implanted as well, we know from the large experience we have with Parkinson's patients that you don't need constant checking. You have it checked externally with a sort of pacemaker type check every couple of months, every few months, which can be done quite quickly in a clinic setting. And certainly, although the capital cost of putting the wires in, is perhaps about £20,000, actually the ongoing costs would be significantly less, and you wouldn't need this huge labour cost of constant checking of the electrodes. So we've been checking the effect of deep brain stimulation on tumour cells, and we found both in adult and paediatric glioblastoma cells that, again, by delivering an electrical field through a deep brain stimulator electrode, you can get a reduction in cancer cell viability, which is fantastic. Here we see different voltages delivered through DBS electrodes. You can see as we increase the voltage, we reduce the number of cancer cells that are available. And we've been comparing this with the in vitro system, the Optune system, again, the company haven't yet tested Optune in childhood brain tumours, but we've shown that certainly in the laboratory, by delivering those sorts of voltages to childhood brain tumours such as glioblastoma, but also medulloblastoma and ependymoma, we can achieve a reduction in cancer cell viability and biological effects on the cancer cells that are promising, and potentially suggest that electrical therapies could be used in childhood brain tumours. And excitingly, we get additive effect when we combine those with chemotherapeutic agents. So a possible strategy could be to enhance the effect of existing or new chemotherapeutic agents through administration of electrical fields, either through the existing Optune system or through a more novel deep brain stimulator-based approach. Thank you.
time for some discussion around those three talks. I'd like to give Stuart a break and ask Shelley a quick question just to get the ball rolling, if that's okay. There was a bit of a moment for me during your talk where suddenly, I think as a parent and also somebody who works with families who are going through a brain tumour diagnosis, the potential impact of that sort of very different dynamic. You've got this triumvirate of opinions in the room, and potentially there's a fourth, the clinical nurse specialist, when you're offering a diagnosis or discussing, how things are progressing. I can understand the challenges there. I'd love to know whether there's been any what clinical input and clinical feedback you've had on your study, and what sort of support are you getting? What does that look like? Even anecdotal comments from clinical teams, because I think there's a time burden here that perhaps isn't taken into account.
Southampton University have already started the feasibility. Can you hear me?
Microphone.
Try this one.
There we go. So Southampton University Hospital have already started the feasibility phase, and I think initially there was a little bit of reluctance from consultants because of exactly what you said. They were worried about the time burden, but then when they tried it, they realised it actually in some cases reduced consultation time because they already had red flags of important things that they needed to ask about, so they weren't spending time asking lots of questions before they got to what was most important. I think that it's probably one of those things that once consultants start to use it, they'll realise that it might save them time actually.
Yeah, because
Thank you. David.
yeah, I think you put your finger on an important point, is how do people adapt their interview technique to incorporate more technology? Now, those are the sort of clinicians, and I look at Stuart, the hospital